So I really don't mind if I hear the rustling sound of chocolates being opened while I present. And thank you very much for coming today. I appreciate that it's the end of the year and it's the time of year when we're all getting really, really busy until we have that date in December where suddenly everything turns to Christmas functions and nothing really happens. But thank you very much for making the effort to come today. Today, I'm not presenting particularly from a nursing perspective, but because nursing is my discipline, there'll be a bit of a nursing focus. But I'm more presenting on the way, as healthcare professionals dealing with these very complex neurological diseases, that we actually need to work collaboratively together and working across disciplines. And if we actually can do that, we probably get much better outcomes for our patients. So just to track on the amount of patients that we're actually dealing with, they're very small in number. The incidence of PSP and MSA are roughly very similar to motor neuron disease, so approximately 5 per 100,000 of population. So they're rare neurological illnesses. The common age of onset is often when people are older, averaging 50 to 60, sometimes a bit younger, but not usually seen before people are actually 40. Men and women tend to be equally affected, so there's no gender divide. And very much the text will sort of say they're a sporadic disorder, they're not contagious. There might be some genetic mutation that you carry, but again, they're not generally considered to be familial illnesses either. And what we do know that's the most significant characteristic, which is probably related to the fact that they are such rare illnesses, is that misdiagnosis is very common. Naturally, we often will sort of think, oh, this patient sort of presented with sort of stiffened muscles and maybe a little bit of tremor and some gait changes. We're probably going to assume Parkinson's disease. And it may well have actually taken us some time to come up with that as a conclusive diagnosis. As we heard in the introduction with Jackie today, Daryl Mooney, who was Anne's husband, who passed away earlier on this year, he had 5 years of misdiagnosis before he got his PSP diagnosis. So we know that these illnesses, misdiagnosis is incredibly common. And often when you're sitting in the patient's shoes, that pathway to diagnosis is quite traumatic. It's quite difficult living with an illness that you know is getting worse and you can feel is getting worse, and not having a label, not having something to stick sort of your head under, not knowing whether what you've got is treatable or not. With the prognosis of these illnesses, it tends to be highly individualised. It tends to be a linear progression, although because the body's actually very good at compensating, sometimes the progression does seem to be a little step-like. We tend to compensate for a number of times for some of those functional declines that are occurring. Then all of a sudden we'll start to decompensate and we seem to deteriorate all of a sudden. And often patients' families will tell you that they can see the progression when they've had a period away from someone. They might have gone into hospital for a stay, might have gone into a nursing home for respite. And when they actually come out of hospital, the patient's not quite the same. They're not able to do exactly what they could do before they went in. Often hospital workers get the blame. You've not given him as much independence, you've not pushed him the way I push him at home. And often that might be slightly the case, but often the case is the fact the disease is continuing to progress in the background. The progression I find in my clinical experiences tended to be really individual. Some patients will progress very quickly and will often go from diagnosis through to very final stages of life in a matter of months sometimes, years most commonly. The mean survival, as put down by the textbooks, is 5 to 9 years. My clinical experience tells me that I've seen people who've been diagnosed and have died within 6 months. I've also seen some patients who, 30 years down the track from having their original diagnosis of MSA, are still around. So it's very much an average. And again, when the patients ask us that question, so how long have I got? When am I going to die? In neurology in particular, and particularly with these diseases, we can never actually give them a date. Because what happens when we do give them a date, they invariably don't die. They come back to us 6 months later and say, I'm not dead yet. You said I'd be dead. And I've had that conversation on many, many occasions with people who a doctor usually has sort of often sort of said, oh look, we actually expect that you're probably not going to live much longer than 6 months, and 2 years down the track they're still in a very similar clinical situation. So again, that prognosis is very individual in the way we work it out, and we have to be very careful when the patients ask us that really hard question, how long have I got to live? We need to actually give them an answer where we're not actually committing to a time frame. So the signs and symptoms that we're going to encounter as a team of healthcare workers, we'll see Parkinsonism, some cerebellar changes and some autonomic changes. And the diseases that fall into these complex illnesses, so MSA, PSP, CBD, and the other illnesses we've been talking about today, tend to affect different parts of the brain. And so often primarily they'll start off with maybe some early symptoms. They might initially be quite cerebellar in nature, with problems with gait and speech. They might be very Parkinsonian, so they might be very stiff, maybe with some tremor and changes in gait. And you will also often see some sort of underlying autonomic symptom changes as well, often changes to bladder and bowel control, and also problems with blood pressure regulation quite commonly. If we're trickling a little bit of levodopa into them, so the anti-Parkinson's medication, we'll often be exacerbating that propensity to actually have some postural changes in blood pressure and that blood pressure regulation as well, particularly if we're dealing with that very early onset where we're thinking, I don't think it's Parkinson's disease, I think it's something else. So often, if we're still giving them, treating them with anti-Parkinson's medication, we need to be very aware that we can actually trigger quite quickly some of these problems with blood pressure regulation. But a whole range of symptoms that we can actually encounter. The other symptoms that we'll often encounter also is emotional lability. Often that is someone with a propensity to maybe to cry frequently, less rarely where someone sort of starts to laugh a little bit and then just can't stop laughing. And sometimes you get those patients who they won't be able to stop laughing and it will soon dissolve into tears. And it's actually a particularly hard one to manage because sometimes what do? You've spoken to someone, they've started off laughing, they've ended up crying. Our natural responses as human beings is to try and comfort the person, but the more we stay there, the more they cry or the more they laugh. So sometimes we have to just walk away from a situation, give someone a quiet time. So they're really challenging us as human beings, symptoms that we encounter. The personality change. People often change in personality, and certainly we discussed this morning how some of those personality changes can manifest. Nighttime difficulties, restlessness and insomnia. Often REM sleep disorders can be quite common and very disruptive for bed partners. So we need to start to think quite early on of carers and making sure that carers are well supported, but also making sure that carers are able to get some decent rest themselves. And I certainly know with MSA and PSP, stridors and nighttime snoring can be really quite loud as well. So often we need to sort of make sure that someone's got a plan B, they've got a spare room that they can go to. And certainly if we're encountering people in hospitals, we might actually have to advocate, often on behalf of the other patients in the shared room, actually this person probably needs to have a single room because they're really quite noisy at night time. And certainly the patients that I've encountered with snoring in particular had been really loud and loud enough to actually keep people awake, even with application of earplugs. We'll see some generalised weakness and fatigue. We see reduced facial expression, similar to what we see in Parkinson's disease, and we'll also see micrographia. We see some cognition changes often in advanced disease, but often these are actually very, very hard to ascertain because often by the time we get into advanced disease, we're seeing significant cognitive change. The patient will often have a communication problem, and so it's very difficult to assess. So this is where we're starting to get the hint that this is an illness that we need the whole team to manage. So to get a cognitive assessment on someone who has mild to quite moderate PSP, you might need to actually employ your speech pathologist as well as your neuropsychologist to actually get a handle on how that person's thinking going. Are they able to make some of those decisions about their medical treatment or who they're giving money to and making wills? Hopefully people will have made wills beforehand, but as we saw from Jim's talk, many of us haven't made wills. And by the time you get caught up in a chronic illness, often you don't get time to actually think about making a will anyway.